Hello, can you hear me? No. Well, if, you know, people ask that, can you hear me? If you can't hear me, then how would you know to say I can't hear you, right? I mean, it's a strange thing. People do it all the time. I do it too, but, you know. Anyway, I want to thank you all for coming. You know, we figured if we fed you and gave you wine, you'd show up. And you're as predictable as we thought you'd be. So now, you know, but you know, nothing is free, so now you have to pay for the meal, and the payment is, I'm happy to enforce that payment, and which is to talk about this new tool that we've developed at the Center for Health Disparities Solutions. My name is Thomas Levis, and I'm director of the center, and my colleague Sherry Wilson is here, and she'll be assisting me in the presentation. You know, I was looking at my computer files and saw that the very first files that we produced for this project was 2002. I didn't realize we've been working on it quite this long. I thought we would have this thing done in about 9 months or so. But I'm glad that we finally are at a point where we can now talk about this publicly. The Center for Health Disparities Solutions is a research center housed at the Johns Hopkins Bloomberg School of Public Health. But we actually go across the medical campus and include faculty from the School of Medicine and School of Nursing as well. And we do research that, as the title of the center would suggest, research with an eye towards solutions to health disparities. We are funded by the National Institutes of Health, the National Institute of Minority Health and Health Disparities. And we've been a center since 2002. You know, this nation is going through a new revolution. Literally, the face of the nation is changing. I don't have to tell you, this audience, that the nation is becoming more racial and ethnically diverse, and that the people that we currently refer to as racial and ethnic minorities are becoming an increasingly larger minority and eventually a majority of the US population. The Census Bureau projects that this pattern will continue throughout this century, and that by mid-century, the United States will be a majority-minority nation. So the consequences of these changes are already being felt in the healthcare system, because ultimately all of the social problems and social issues that occur in a society find their way into the treatment room. And the problems, I don't have to tell you, include issues around trust, incompatibility of disease, explanatory models, which leads to reduction in quality of care. We also have problems around safety. There are also cost implications for the healthcare industry. So we have this rapidly rising costs in general, but also costs related to the increasing diversity of the country, increased length of medical encounters, fewer patients being able to be seen, and it's taxing the system. There's an increased risk of litigation, a recent article shows. So we have real problems. Also, the regulatory environment. This is a picture of my secretary, and the regulatory environment has been changing to respond to the changing nation. And some of you here have contributed to those new regulations. You know, we all know about the class standards, of course, and which were revolutionary in placing emphasis on the issues that we're all concerned about. The Joint Commission standards, which will go into effect in January, will also have, I think, an important impact on the healthcare industry. NCQA has its standards that came into effect earlier this year. NQF is also doing that. It also has standards that will be coming out. And then there's the new meaningful use requirements for electronic health records, which is going to, for the first time, require the collection of racial and ethnic data in health systems. It's going to be very important, and we're going to have to figure out how to make the best use of these new resources that will be coming to us. One of the issues, however, is that especially those of us in the research community, I think we have failed to adequately create an evidence base around what we do to address cultural competency in healthcare. Surely there are things, there are programs, we've heard about some of those programs at this conference, and there are people doing a lot of very important things, but we're still all at the very beginning of creating an evidence base around how we can change, how we can make change. And I know some of you have, like me, been frustrated, who've been working on this topic for a very long time. I first started working on cultural competency in the early 1990s, and mostly what we had then was think pieces and essays about the importance of dealing with cultural issues. It made sense to me, I accepted it on faith, but as a researcher, we hadn't done much to clearly define these terms, measure them, and figure out how we can begin to learn how we can make change. Frustrated, I went away from cultural competency for a while. At that time, we had what I call the first generation of cultural competency, which was pretty much stereotype training. We would teach everyone the stereotypes. So patients from the Middle East are like this, Hispanic patients are like that, and we would just teach all the stereotypes, and that's what we did at that time. We've evolved beyond that, thankfully. But when I came back to cultural competency, I learned that we hadn't done much around this evidence base, around measurement issues, that we were still writing a lot of think pieces and essays and not giving the industry what it needs, which is concrete solutions to problems. So we started thinking, what can we do at the center to help to address these two problems? And I'm going to talk to you about one of those things tonight, and I'll mention the second thing a bit, but mainly I want to talk about this new tool, the COA360. And for those of you that'll be here tomorrow morning, I'll talk a little bit more about the other program in tomorrow morning session that I'll be speaking on. So the COA360 is a web-based tool. It's done entirely on the web. It's an assessment of healthcare organizations, and it's important to point out that's an assessment of healthcare organizations, not individuals. We're not assessing people and whether an individual person is culturally competent. It's whether the organizational culture is culturally competent and therefore likely to produce outcomes that are better for diverse populations. It identifies strengths and also areas for improvement. It's suitable for large or small systems because the assessment tool assesses units of a hospital. It doesn't assess the entire hospital. It assesses a department or a service or some other subunit of hospitals. So it can be deployed in any size healthcare organization, not just a hospital, frankly. Any organization should be able to use it. And it's robust enough to work within the unique configuration of diversity that your organization is operating in, whether it's racial, ethnic, linguistic diversity, religious diversity. It's also robust enough to allow the user to indicate what type of diversity, the other types of diversity that they may be interested in. For example, you may have an organization that has a large LGBT population. You can put that in and ask a series of questions around that community as well. So it's very robust. It's focused to a large extent around the class standards and the Joint Commission standards, as well as other domains that we created as well. So I'm going to turn it over to my colleague Sheree Wilson, who will walk you through the system and some of what it does.
Great, thanks Tom. Can everyone hear me? Great. So the COA360 will provide a 360-degree view of your organization. And what's wonderful about it is that there were 5 surveys that would be completed. There's someone for your organization who would serve as a point of contact. That person's the point person for the organization. That person actually completes a survey that asks about the perception of the percentage of patients who fall into the different religious, ethnic, and racial categories. You then get feedback from your administrators, who would basically serve to be the leadership perspective. You would get feedback from your clinical staff, so anyone with direct patient care, your non-clinical staff, so people as housekeeping, nutrition staff, unit clerks, security, as well as probably most importantly, your patients. The goal, too, of the COA360 is to help an institution establish where its baseline regarding its cultural competency efforts. The idea is that you would complete an assessment, see how you're doing, and then you would implement some sort of solution. And you would probably go back within another year or two to see how well that solution has been implemented and whether that solution has actually helped you improve your scores in the various domains. The COA360 in 2008 was awarded the Innovation Award by the National Institutes of Health, National Institute on Minority Health and Health Disparities. Okay, so once a user has been created, emails are generated. So the user will receive an email letting the person know you have now been assigned to complete one of these surveys. The user's username will be typically an email address, and then when the person logs into the system, the person will then find which survey the person is to complete. So actually, if you look here, this happens to be City of Hope Hospital, and this person now is being prompted to complete the patient or client survey. What's also very nice, too, is that this basically speedometer tells you your progress so far on the particular survey.
Oh, geez.
Oh, did you want to introduce?
No, you can't.
Oh, okay. Sorry.
You can really see what it says very well.
Oh, okay.
Yeah.
In addition, all survey respondents, including the point of contact, are asked questions about their background, so demographic information. So basically, if it's your clinical, non-clinical, and administrator staff, it asks, how long have you worked in the healthcare industry? How long have you worked for this particular unit? And if you're a patient, it asks, how long has it been since you've been a patient of this particular unit? And that data is then pulled into the overall report.
Advance for you.
Thanks. Okay, thanks. So as Dr. Levis mentioned, some of the questions are based on class standards as well as some of the Joint Commission standards. And in addition, some of the other questions are based upon original research that has been conducted here in the Hopkins Center for Health Disparity Solutions. So what you'll see here, these are questions on the staff surveys, and basically what it does is it asks the staff members to rate what they think are the organization's values and processes, and then this creates an organizational change matrix. And what's unique about that is it basically helps to demonstrate what is your organization's willingness or readiness to change. So we can kind of determine up front how successful they might be with this operation. And then lastly, you'll see that there's a cultural inclusion vision, which is also generated. And then for the patient-client survey, we have 3 unique domains. One is asking about patient-client satisfaction, one asks about discrimination and bias, and then lastly, one asks about patient trust. Once the complete assessment has been completed, so all surveys are now closed, you will not have to wait for any extended period of time to actually have access to your report. The point of contact will log into the system, click on a particular link, and then a PDF report will be generated for that. The COA360 report includes several sections. It has an introduction. I'll go through each of these sections actually. An introduction, interpretation guidelines, and then there are 4 sections. One called Unit Diversity and Representativeness Summary, a Respondent and Patient Demographics Summary, a Performance Domain Summary, and then an Organizational Change Matrix. So in the introduction, this basically provides an overview of the report components. So you can see there's the introduction, and it talks about the 3 sections that I just mentioned. Next, in the interpretation guidelines, it tells you basically how to read each of these sections and basically read through the suggestions that are provided so you can try to improve your organization. There also is an assessment completion summary. This basically tells you how many surveys were actually created, how many were completed, and then what was the overall completion rate. So first, the unit diversity and representativeness section basically will summarize the racial, ethnic, and religious diversity of that healthcare unit's patient population. And that is based upon the survey completed by the point of contact. Next, the respondent and patient demographics section summarizes the racial, ethnic, and religious diversity of the respondents and patients who actually completed the survey. The meat of the report, though, is the performance domain survey, and these sections of the report actually will guide the unit to see how well it actually is performing on the various domains. And what you see here, what you see here actually is this is a roll-up. The red bar is a roll-up of all of the employees. This is how all the employees rated the units, how the administrator rated the units, clinical staff versus non-clinical staff. And what's great about this, it will show you where basically there is a disconnect. Because as we know, our administrators, our leadership tends to rate the organization very highly, right? What do we hear? Oh, but we have a policy in place for that, right? But then when you go and actually talk to the staff, okay, so I hear you have a language access policy in place. How How frequently do you call interpreters? How frequently do you rely upon bilingual staff? How frequently do you actually use a family member to serve as an interpreter? That's where you'll actually find out how things are actually working in the trenches. And this is actually showing the discrimination and bias. So in this case, not only are you seeing, again, the roll-up of all employees, the administrator, the clinical staff, the non-clinical staff, but then this blue line is basically how the patients or clients are actually rating the organization. This report then will state basically what is the difference between the way all of the employees are rating the organization versus how the patients, and it'll give you a number. In addition, it gives you commentary on how you can improve, and then we also have tables where there are at least 3 respondents in each of the racial, ethnic, and religious categories. It will tell you then how those particular groups actually rated the organization, so you can drill down even further. So for example, this happens to be discrimination bias. So if you looked at your figures, it could say, okay, in our white population, they think we're doing a great job with treating all patients equally, but oh, let's look, in our Middle Eastern population, we're not doing as well. So it really does help you focus on the areas that require improvements. And then lastly, we have what we call the organizational change matrix. I had mentioned the organization value and organizational process. That asks the employees how they would rate certain or rank certain values in the organization as well as certain processes in the organization. It then produces a percentage, and then it produces a matrix which then lets you know whether you have, what kind of an organization you have. So there are 4 kinds of organizations you could have: agree, 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 disagree, 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 agree. And it states, basically, in this section, based upon the kind of organization you have, what are some of the strategies to try to implement change in that organization. And then the last section of the report is this cultural inclusion agreement. It asks questions such as, how important is cultural competency in our organization? Is it the most important priority in our organization? Is it not important at all? Is it important, but it's one of multiple priorities? Or we've done enough already on cultural competency. And it gives you a rating, and again, it lets you know areas in which you can improve. And now I'll turn it back over to Tom.
So just a couple of things. I pointed out that this is an assessment of units of an organization, not the entire organization. When you think about a complex organization, a big hospital, depending upon which door you enter as a patient and which department you go to, you can have a very different experience. So you couldn't have an assessment tool that would do the entire hospital. You have to assess units of the hospital. We are, however, creating a hospital-wide assessment, which we would hope to launch early next year. That one focuses more on policies and procedures at the hospital level that are controlled by the hospital administration, not at the unit. So we are working on that. I would also say that we are a research organization. We're not cultural competency consultants or trainers. We want to work with people that do that work, and we want you to deploy this tool in your work, and hopefully, and part of it is that we're interested in collecting data and conducting research on it. Just to be perfectly candid, we'd like to be able to show a relationship between cultural competency and quality. That, to me, is the holy grail. Can we empirically demonstrate that? So we're building a database within this tool, and so we'd like to bring in as many of you that are doing this kind of work into the work that we're doing, bring clients to use the system, use the tool, and see if we can document that. So we're not looking to compete with cultural competency trainers, but rather we're looking to work with you. We would like to develop, and we're working on developing a program for trainers where they would be certified users and understand how the system works and be well positioned to work with the client around this, with the system, to be able to find solutions to the client's unique problems. The other thing is language. Right now it's only available in English. We're going to be working on having it translated into other languages, and over the coming years we hope to produce different language versions of it, as well as versions that could be used in other countries. Right now it's very focused on the US, but we'd like to also be able to eventually move into other countries as well. So we're going to, I know you want to see the film, and I don't want to hold you up too long, and I'm sure there are lots of questions. So what we're going to do now is we're going to stop and take some questions. We have microphones strategically placed around the room, and please come to the microphone, ask any questions you may have about it.